So I'm going to talk about the role of radiation in patients with oncogenic drivers. As Dr. Bazhenova pointed out, I'm from Memorial Sloan Kettering Cancer Center. These are my disclosures. And so when we think about non-small cell lung cancer and outcomes for non-small cell lung cancer, I always, and have done so for about 15 years, started with biology. We all understand, whether we're patients, patient advocates, family members, scientists, clinicians, nutritionists, so forth, that biology really is critical for effectuating outcomes. You've heard it from a number of our colleagues today. And, this section is focused on targeted therapy, and certainly EGFR mutant positive disease, ALK mutation positive disease are critically important for driving outcomes. And what I would like to argue, and what Dr. Singhi was getting at, is that the role of the pattern of disease distribution, whether it's oligometastatic versus polymetastatic, the relevance of acquired mutations and resistance mechanisms across variant evolution is all going to play an immense and holistic role in how we treat all of you. And the reason that it's important is because systemic therapy is getting better. This is a chemo IO study, but it was actually predated by a number of years by very critical targeted therapy trials. But the important point to note is that we are doing better and better because of our medical oncology colleagues and our scientists, and of course our patients who took part in these trials, to improve systemic disease control with systemic therapy. But what I would like to always argue is that these treatments are not as durable as we would like. They don't have a depth of penetration as we would like. And so therefore, we want to do better. And so aside from improving systemic therapy, which I know is going to happen date by date, year by year, we want to see if other treatments can also play a role, local treatments. And when I talk about local treatments, it's both radiation and surgery. So why have we started talking about local therapies, radiation, surgery in the metastatic setting beyond palliation? Because for up till about a few years ago, we would only use these therapies for improving palliative symptoms, whether it's pain, bleeding, shortness of breath, etc. But as systemic therapies got better, we started thinking maybe there's a role for local therapy in improving survival outcomes. And then we still had a niche because these systemic therapies weren't perfect. They weren't curing or providing long-term durable benefits for all the patients. With imaging, we started finding metastatic disease earlier to be able to understand whether they could be benefited by targeting with local therapy. So we asked the question, can local therapy promote a situation where we turn disease that was once not salvageable into a chronic illness? And so we have a lot of evidence for that in other cancers beyond non-small cell historically. You take sarcoma patients that were metastatic to the lung or liver. You take colorectal cancer patients metastatic to the liver. These patients had these areas surgically resected. And so the surgeons were really at the forefront of showing that surgically removing some of these sites of disease was actually beneficial from a survival benefit. Then we started looking at our non-small cell lung cancer patients and those with isolated adrenal metastatic sites of disease that were resected, or brain mets that were resected or treated with SRS. Those patients started doing better and better.